Well, you're in the right place. This is Optometric Education Consultants National Webinar Series for Tuesday night, also known as the Greg and Joe Show. It is our very distinct pleasure to welcome back Dr. Lighthizer. He is Associate Dean and Director of Continuing Education and Chief of Specialty Care Clinics at the Oklahoma College of Optometry. We've had him before. We're going to have him again on other webinars. He is one of the top minds, thought leaders, and people who advance the profession. He's a tremendous person. He is a top-of-the-line speaker and just an all-around great guy. So with that, my great privilege and pleasure to introduce and welcome Dr. Nate Lighthizer, who will be talking about swollen optic nerves. Now, Nate, take it away, please.
Thanks, Joe. Quite an introduction. A lot to live up to there. I appreciate the kind words. Right back at you and Greg and everything that you guys do with your optometric education consultants, leaders in the profession, leaders in your individual states as well. So I just want to thank you guys for the invite. It's my pleasure to be here. Looking forward to the next hour and 40 minutes on swollen optic nerves. As Greg said, we're going to keep this very, very interactive. I know it's hard to do that in the virtual setting, the virtual arena. But again, we're going to do that in multiple different ways via the poll everywhere, which I'll introduce here in just a second, but also via the chat box. If you have any questions, any comments, tips, pearls, nuggets of wisdom that you have, I'm going to ask you for various questions that are not via poll everywhere. Then I might just say, hey, type it in the chat box real quick. What do you think of this or that? And we can interact that way as well. So both via the poll everywhere as well as the chat box. So I encourage you to go ahead and open up that chat box. I've got it open in my bottom right screen. You can't see it, but I can see it, and I will be monitoring questions, tips, pearls as I'm going throughout this lecture. So please, if you have anything at all, open up that chat box and we can interact that way as well. So swollen optic nerves, as Joe said, I'm down in Oklahoma. I'm down in Oklahoma here and at Tahlequah, Oklahoma at the College of Optometry. And I've been there for about 12 years now where I serve in various roles there. So again, swollen optic nerves. Now what? Here's my disclosures. As you can see, my disclosures right here. You can see we'll keep this within the guidelines of a COPE approved lecture, keeping this very non-biased as we go throughout this lecture. Poll everywhere. Again, if you're going to be on your phone anyway, right? So you're already on your computer or your phone, open up a different web browser or a different tab, I should say, and type in pollev.com/Nate Lighthizer, POLLEV.com/Nate Lighthizer. I just typed it into the chat box, as you can see right there. So it's in the chat box, POLLEV.com/Nate Lighthizer. That is my poll everywhere page. And I'm going to do a little intro question here in just a second. I'm going to get back to that in just a second. So I'm going to leave this up for just a minute or so, pollev.com/Nate Lighthizer. The reason I like to do this is nobody likes to raise their hand in a lecture, whether it's in person or whether it's virtual. This is a completely anonymous way to poll the audience. Nobody's going to know what you put. I won't even know what you put as we're going throughout this lecture. So I encourage you again, log in. We've got about 110 of you on the call tonight. Nice big group. Here's what's nice about this is that, again, nobody will know your answers, but we'll know what percentage of the group put A versus B versus C versus D versus E. So you can kind of see the group thinking in general, big picture, not an individual answer, but the group going, oh, okay, most people know this. They're thinking A, but I was thinking something else. Maybe better pay attention to this or whatever it be. So POLLEV.com/Nate Lighthizer. That is my poll everywhere question. I always do an intro. And again, giving you a couple of seconds to log in here. Greg and Joe's great CE, OEC, the Ophthalmic Education Consultants. They have live meetings every year. I was on their website today. Looked really, really cool, really well done. They've got 4 locations this year: Nashville, Scottsdale, Ponte Vedra Beach, Florida, and Mackinac Island up in the UP in Michigan. Those are 4 different locations that they're going to be this year. Which location would most appeal to you there? All right, we got over 30 answers already. Keep those answers piling in. I'm going to ask you, various questions about swollen optic nerves. What do you think? Do you think this is edema or papilledema, or do you think this is pseudoedema? What do you think is causing this optic neuropathy here? And again, a completely anonymous way to poll the audience. And what's cool is, again, I'm going to hit a button here, very simple, very straightforward, and go, boom, there we go, right there. And you can see the different locations that you guys are pretty split evenly across the board with 3 answers: Nashville, Scottsdale, and Mackinac Island in the UP of Michigan. There, not a whole lot of love for Ponte Vedra Beach at this point right there. So there's that's how we're going to do the polling over the course of the next hour and a half or so. I always like to show pictures of my kids. There's Addie and Camden. They're now 9 and 6. So this picture shows them from a couple of years ago already. There's us at Disney World. This might have been lecturing at Joe and Greg's previous forays or CE conferences in Orlando there. One other picture. I always like to start with a little kind of fun stuff, pictures, things like that. There's a lot of places that you can do CE. We just did a polling question on the various places you can get CE with OEC, Greg and Joe. I was asked to lecture at a unique place a couple of years ago. It was a combination fishing trip, CE trip. You know, you can go on a variety of CE trips. You can go on golfing trips. You can go to Europe. You can go on cruises. This is obviously all pre-COVID, but I had never heard of a fishing trip combination CE trip. I thought, well, this is interesting. I like to fish. Growing up in North Dakota, I always went to Canada fishing with my relatives. Every year we had a fishing trip with my dad and my grandpas and my uncles every year. So I said, this is great. Let's go to Canada for a fishing CE trip. And I did that. I lectured like 12 hours over the course of 4 days, and we fished for 5 days in a row, like fished all day long. And then we came in and people had dinner and they were having beverages and having a good time. And I got to lecture while they were doing that. And I got to catch, I forgot about this. I messed up my pictures here. Anybody know what this picture is? Via the chat box. Anybody know which activity am I playing? Greg, I bet you know what this is, buddy. I bet you do. You look like that you'd be somebody that would play this. I know you're a golfer, Greg.
I am, but yeah, I've only played this a handful of times, so I do know what it is. But maybe as I get a little older, I'll be playing this a little bit more. So.
And you can see, hey, now it's not just reserved for older people now, Greg. I'm now 39 and I'm playing this, and it's a lot of fun. We got 3 people identifying at pickleball there as well. Greg, I bet you and Joe are really good at this. Need more lines there. There you go on that one. So there's the pickleball right there. There's one of my North Dakota pictures right there. Here was the last one I was going to show you, that fishing CE trip. I got to catch this.
Wow.
Now, via the chat box, does anybody know what that is? Again, via the chat box, what do you think here? Let's interact back and forth. Anybody know what that is? Look at that. We've got a pike, we've got a muskie, we've got a pike again, we've got a muskie. Pike and muskie, they're like cousins. That's a 42-inch muskie that I caught there. That's actually not a great big one. I went back a couple of years later and spoke again, and my dad caught a 47-inch muskie there. So wanted to show you those pictures. Start a little light. A carp. Nope, not a carp on that one. We're not catching carp, but that is a muskie right there. All right, on to business.
Now it could be carpe diem.
Carpe diem. There you go. Seize the day. That's exactly right. That was a good day. Any day fishing on a lake up in Canada, beautiful weather, is a good day. It's a fish. Yes, Dr. Gordon right there. Dr. Ross. That's a fish. I always love that. It's a fish. It's a big fish right there. On to business. All right. So we're going to talk on this. And, you think about when you see a patient that has the back of the eye that looks like this, doesn't your day get a little bit more complicated when you see this in one eye and or both eyes as well? I mean, your day is going to get a little bit more complicated, a little bit more busy, because now you've got to go through the variety of things that could be causing this, from the very, very benign to the very, very worrisome. That, could be a brain tumor, could be something very, very severe that has a significant morbidity and or mortality associated with this as well. So, your day got more complicated, almost as complicated as double vision. You guys ever cringe when you get a patient in your chair that says, I'm seeing 2, doc, or I've got double vision? Have you ever tried to talk a patient out of double vision before? Are you sure it's not shadowing or something like that? Again, I say that jokingly, but it just goes to the point that oftentimes your day is more complicated with double vision. and when you see a nerve that looks like this as well. This could be buried optic nerve head drusen. This could be just a small disc. This could be something, again, like a brain tumor, a bleed, something like that. But you gotta know a lot of things about this patient before we decide what could be causing it. Is it one eye? Is it both eyes? What's the age? What's the demographics? Again, that's the nature of this lecture. Dozens and dozens of things could be causing this. What is actually causing it? That's our job as the optometrist, as their eye care provider there. And you're going to see this case in about a half hour as we go through this lecture here. So again, here's a kind of thought of a nice kind of flow diagram of looking at optic disc elevation. In my mind, one of the first things that I need to determine is that nerve that looks elevated, that is elevated, and it looks swollen, is it actually swelling, or is it pseudo swelling? So the first thing I always try to differentiate, is it true swelling or is it pseudo swelling, pseudo papilledema, from small discs? Maybe it's a tilted disc. One of the most common causes of optic disc drusen could be causing that as well. Is there true swelling or is this pseudo swelling? You can see that's kind of the first branch that we go down right here, true swelling versus pseudo swelling. I'll tell you, more often than not, the majority, it's probably pseudo. I see more cases of elevated nerves that maybe borderline, is it swollen? Is it not? Nope, it's actually not swelling from, again, tilted discs, small disc, buried disc drusen or optic disc drusen, common causes of that. So we often, this first split, will go down this path. However, if I think it's likely true swelling, then we get into is this papilledema or is this non-papilledema? What's the definition of papilledema? And I was very fortunate. I spent about 3 months with a neuro-ophthalmologist during my training about a decade ago, 12 years ago. And I always remember him saying that, the definition of papilledema is bilateral disc swelling secondary to raised intracranial pressure. You all know that's the definition of papilledema. It's bilateral in the definition. Now, could it be asymmetric? Could one eye present a little bit more before the other eye? Certainly that is true, but bilateral disc edema secondary to raised intracranial pressure, that's papilledema. Is there true swelling? Certainly there is true swelling present. Remember that definition. So if we think it's truly swollen, one of the common roads we will go down is this papilledema. But if it's unilateral, if you don't think it's necessarily papilledema, it's in one eye only, and you think, all right, I got true swelling, but it's not papilledema, that's where I always remember the 3 I's and the 3 T's. I always remind myself that. Is it one of the 3 I's? Is it one of the 3 T's? Well, what are the 3 I's? Ischemic, one of the more common causes, inflammatory, or infiltrative. And you can see the 3 I's kind of right in this area. Inflammatory, optic neuritis, going to be one of the most common causes of an inflammatory true optic nerve swelling. And again, we'll talk about who's more likely to get this in just a few minutes there. Inflammatory, optic neuritis. Yes, can be other things as well, but optic neuritis can be the most common. Is it ischemic? Something like a vein occlusion, an ischemic optic neuropathy, either non-arteritic or arteritic. NAION is going to be more common than AAIONs from giant cell or temporal arteritis. So is it inflammatory or is it ischemic? The third I, is it infiltrative? I would call this more of the zebra. We teach our students and residents, I'm sure you've heard it before. You think horses versus zebras. I'm much more likely to see a horse wandering down the street or in the field than I am to see a zebra, unless you're in other parts of the world. But in America, unlikely to see a zebra. Same thing in the optometric practice. Horses before zebras. And I would say of your truly swollen nerves, your optic neuritis, your ischemic optic neuropathies, those are more of the horses. A zebra may be more infiltrative. Doesn't mean you can't see it, but the leukemias, the lymphomas, things like that. Again, that's the third I. Inflammatory, ischemic, infiltrative. How about the 3 T's? Tumor, trauma, and toxic. And again, I would say all of these are maybe a little bit more along the lines of zebras, but it could be that tumor, optic nerve head glioma, meningioma, something like that, or other brain tumors as well. So it could be a tumor, it could be trauma. Hopefully that will be an easier differential as they've had some sort of significant trauma. And then is it toxic as well? Going into the various causes of toxic optic neuropathy, from medications to lead to alcohol poisoning, things like that. Again, tumor, trauma, and toxic. So I always remember the 3 I's and the 3 T's. I think the main point of this kind of flow diagram is I don't often get to the 3 I's and the 3 T's because, okay, all right, this nerve looks swollen, it's elevated, but it's not actually swollen. So it's pseudo papilledema, or you know what? It actually is swollen, but it's in both eyes. Maybe it's in an overweight female. I think it's idiopathic intracranial hypertension, or it's papilledema from something else because it's both eyes. Then we go down papilledema. I think the third most common road is probably this road here with the 3 I's and the 3 T's. So it's not often, but we certainly got to keep it in the back of our minds to rule it in or rule it out in the right case there. So again, just a little flow diagram that may or may not help you as you're looking at those swollen optic nerves. But again, the point is, what's the first differentiator? We do this clinically. You're looking at a nerve and you're going, all right, that nerve looks elevated. The nerve is definitely elevated. Is there swelling, or is this truly just pseudo swelling at this point in time? So how do you differentiate swelling versus pseudo swelling? And obviously the first way is you're going to be the eye doctor. You're the doctor, dilate the patient, take a look. Is this truly swollen? Is it not swollen? How do you determine that? Are the vessels blurred as they cross the disc margin? That's one of the first things that we're going to look at. And we'll come back to the SVP in just a second here. So, you take a look. In true swelling, there's a swelling of the nerve fiber layer, the retinal nerve fiber layer, and that can, not always, but it can engulf those blood vessels as they cross the disc margin and cause blood vessel obscuration, blood vessel blurriness. Basically, it can engulf some of these vessels, and instead of being nice and sharp and crisp, as we see on an everyday basis in our normal patients, you may lose sight of some of those vessels. Sometimes it's the big ones, sometimes the small ones. They don't have to be totally gone. Sometimes they can just be a little bit blurry. But the point is dilate your patient, take a good look at the back of the eye with your 90 diopter, your 78 diopter lens, and take a look at those blood vessels as they cross the disc margin. Are they obscured? Then maybe you're tipping towards there maybe is some true swelling there, or are they crystal clear as they cross the disc margin? Much more likely to be pseudo swelling. True drusen, optic nerve head drusen, it would be very unlikely that it would cause a swelling of the retinal nerve fiber layer and a blurring of the vessels. That's why, again, they're usually crystal clear, those vessels, in pseudo swelling, in drusen, small discs, etc. Versus if there's true swelling, a swelling of the retinal nerve fiber layer, and that can engulf the vessels, obscure the vessels, and you can get blood vessel obscuration. Is it a perfect test? No. There is no perfect test as we look at these, and you're going to hear me say multiple times, there's no one test that you can hang your hat on and say, aha, that's going to tell me whether this is true swelling or pseudo swelling. There's just a lot of different things that we look at, and you add up the entire picture, kind of like glaucoma and other things. There's no one perfect test for glaucoma, and there's no one perfect test to tell you true swelling versus pseudo swelling. But you should start by taking a look at the discs. How do those blood vessels look here? And you can see in this case, obviously this is a case of optic disc drusen. You can see the lumpy, bumpy appearance. And even though it's a little bit of a blurry picture, notice that crystal clear as those blood vessels cross the disc margin right here. Zero blood vessel obscuration, looking good in this case right here. This case right here as well. Here's another case of optic disc drusen. As you can see here, notice the blood vessels crystal clear as they cross the disc margin all the way around here. So again, here's my thought. I want to get your thoughts on this one. Here's mini case number one. You're not going to vote on this one via poll everywhere, but I want to get your thoughts via the chat box as we're looking at here. Mini case number one. This is a 28-year-old female. Okay, 28-year-old female that just walked into your practice. Okay, a 28-year-old female, first time you've ever seen this patient. She's in for a general exam. She's got some headaches, but she's always had some headaches in the past. She is a headache person. Knock on wood, fortunately, I'm not a person that gets headaches, really never have, but I have relatives that they just suffer from a lot of headaches. I have a good friend at the school, suffers from a lot of headaches, migraine headaches, things like that. This 28-year-old female is a headache person. She said, I've had headaches really all my life. And you take a look and her vision's pretty good and she's just in for a general exam, but you take a look at the back of the right eye and the back of the left eye. And I'm guessing you will see that, these margins are not totally distinct, especially in the back of this right eye, maybe a little bit better in the back of the left eye. I will tell you the nerves were elevated just a little bit, but we've certainly got indistinct margins. We have got elevated optic nerves, And the question is this true swelling versus is this pseudo swelling? So again, how do we do that? Well, let's look at the blood vessels now via the chat box. Again, via the chat box, give me a yes or a no. Do you think there's blood vessel obscuration here? Yes or no via the chat box. And there's no right or wrong answer here. I just want to kind of get a summary here of this. We got no, no, no. We got a yes there. We got a couple of no's. And great. I love this feedback. We've probably got 2/3 to 3/4 of the answers are saying no at this point. Again, this is not, there's no right or wrong here. There's no perfect answer on this, but I would say 3/4 of you probably leaning towards no, 25% of you leaning towards yes in this one right here. I would tend to agree with the majority that if I had to tip in one direction, I would lean more towards no versus yes in this case in the right eye. And there's the left eye as well. Again, I'm not going to give you the answer yet. I'll get there in just a little bit. How about mini case number 2? Now, this was a 23-year-old asymptomatic male. 23-year-old asymptomatic male, no symptoms, no problems, no concerns whatsoever. And you take a look at the back of the right eye here and the back of the left eye here. This patient is 2015 in for a general exam, no issues, no complaints, no concerns whatsoever. And again, the nerves look elevated. The margins look indistinct when you're taking a look at these. So I'm going to ask you one more time in mini case number 2, blood vessel obscuration, yes or no? What do you think? Which way you leaning in mini case number 2? Right there. There's the back of the right eye and the back of the left eye. And Joe and Greg, I see you're probably monitoring the chat. Love all these answers. Look at these answers coming in. This one, it looks to me we're split more kind of 50-50. We've got yes, no, yes, yes, yes. We've had a bunch of yeses and a bunch of no's. So we're much more closely in this one. I think you could go either way in this one. If you forced me to choose, maybe I would lean towards no on this one. But again, there's no perfect test in this one. Yeah, left eye, I think definitely looks worse than the right eye. I agree with Dr. Scott on that one. You know, right eye, maybe not. Left eye, maybe so. Again, can't hang my hat anything great on this one in terms of the blood vessel obscuration on that one. So again, we could go either way in this one. How about mini case number 3? Now, this is an interesting one. This is a 32-year-old Asian female. 32, catch this, why she came in. 32-year-old Asian female comes in because she said, Doc, you know, for the last 2 months, the world is just brighter. It's like when I go from a dark room into a bright room, it's like, wow, things are just bright. I'm light sensitive. The world is just brighter. She is 20/20 plus in both eyes. And she's almost having photophobia complaints, which you would think is that iritis, uveitis, something like that. But anterior chamber's fine. Her eyes are not red whatsoever. Her only complaint, it's not blurred vision. It's just the world is bright. Something has changed in the last 2 months. Thing is just brighter. I'm having problems going from a dark room into a normal room or a bright room. It's just, woo, that is bright. Anterior chamber's clear, eyes not red. So you'd think, I mean, 2 months, that's not an acute uveitis. It's not chronic. There's no cell and flare in the anterior chamber, but yet the back of the right eye looks like this, and the back of the left eye looks like this. So again, are the nerves elevated? Yeah. Once again, my question to you in mini case number 3, is there blood vessel obscuration? And it seems like we're unanimous on this one of clearly there is blood vessel obscuration in this one, in this 32-year-old Asian female. Now I'll give you the answer on this one. 32-year-old Asian female that came in, and again, her world is bright for the last 2 months. That's it, not blurred vision. And obviously we have got severe elevation, what looks to be severe swelling. Obviously there's blood vessel obscuration. It's bilateral in a 32-year-old normal weight female. And again, you can get pseudotumor cerebri, which is really an older term now, because when you call it pseudotumor cerebri, what did the patient hear? The patient heard tumor. When I like the term idiopathic intracranial hypertension or benign intracranial hypertension. Again, that's usually seen in younger, overweight females. That's not the entire demographic. It can happen in other demographics. But this 32-year-old female was was normal weight, actually a low BMI. She was worked out a lot, was very fit, 32-year-old Asian female. As you all know, IIH, idiopathic intracranial hypertension, is a diagnosis of exclusion, which we'll talk about in just a little bit. We've got to rule everything else out. She had a big brain tumor. She had a brain tumor that did turn out to be grade 2 malignant, that had 92% of this tumor removed via surgery, and then had some chemotherapy and radiation on top of that as well. So again, blood vessel obscuration, obvious. This was a case of papilledema, elevated intracranial pressure, not from pseudotumor or IIH, from an actual brain tumor in this mini case number 3. So even though it's more often, this one, maybe this is pseudo-swelling, mini case number 1, we're thinking maybe this is pseudo-swelling. Mini case number 3, we have got true swelling here. We had papilledema in this case from a brain tumor right there. Here's mini case number 4. And this was also a 32-year-old, but this is a 32-year-old African-American female. 32-year-old African-American female. There's the back of the right eye. Here is the back of the left eye. And again, nerves are elevated. Certainly they look swollen. Is there blood vessel obscuration? My last question to you on mini case number 4 here. And once again, the answer is unanimous on this one is yes, yes, yeah. Obviously, we have blood vessel obscuration. Interestingly enough, also a normal weight 32-year-old female, African-American female. Obviously, the great big hemorrhage gives it away that this is not going to be pseudo-swelling or pseudopapilledema. Small discs, tilted discs, optic disc drusen shouldn't be causing that. This was not pseudo-swelling. It was not papilledema. This was one of the 3 eyes in this 32-year-old female. Inflammatory? Nope. Ischemic? Nope. Infiltrative. This was infiltrative. This patient turned out to have leukemia. So even though it's not often the 3 eyes and the 3 T's, I shouldn't say it's not often. It depends on the demographic. The most common cause of optic disc swelling in somebody over the age of 50 is an NAION, so an ischemic optic neuropathy. So that would be one of the eyes. But as you're going through that differential, remember the 3 eyes, remember the 3 T's. It's not always going to be that, and that may be more likely to be papilledema. It may be more likely to be pseudo-swelling or pseudopapilledema, but keep the 3 I's and the 3 T's in the back of your arsenal, in the back of your diagnostic armamentarium as well there. Again, here's another one. This was a case of pseudotumor cerebri. This was bilateral, even though I'm not showing you both nerves here. Clearly, we have got blood vessel obscuration. As you can see, this big disc, excuse me, I should say this big vessel disappearing here, these vessels disappearing. So take a look at the back of the eye. Can you hang your hat on it all the time? No. Dilate them. Look at the back. Are those blood vessels obscured? If they are, that's pointing you down the road of true swelling. If they're not, then maybe it's more likely pseudo-swelling in that particular case there. So take a look at the vessels as they cross the disc. Is there spontaneous venous pulsation? Again, I was trained in part by a neuro-ophthalmologist at the Mayo Health Clinic up in Minnesota, and he had a saying that if you see spontaneous venous pulsation, is that a good thing or is that a bad thing? Again, via the chat box, if you see SVP, good or bad, type it in the chat box, good or bad if you see SVP. Do you want to see that, good or bad? And again, you guys all know this. It's good, good, good. Yeah. If you see this, see how he is saying that if you see it, the chances of them having raised intracranial pressure is very, very little. So SVP is a good thing to see. You hope you see SVP when you take a look at the back of the eye. Now, what percentage of patients that you see in your clinical practice, what percentage of normals, should I say? Let's assume you see normals day in and day out. What percentage of the normal patients that you see in your practice have SVP? Type in a number. I'd be curious to see what you think. And while they're typing in a number, Greg, Joe, what are your thoughts? What percentage of normals have spontaneous venous pulsation? We've got answers from 10% to 80% on the board. And I think that's really showing that it can vary widely. Do you guys have any thoughts on that?
Yeah, I think about 17.5% will have spontaneous venous pulsation.
Did you say 70 or 17?
17.5%.
Okay. So you can see most of you are 10%, 25%, 20%, 20%, 50%. So what does that mean? If you see it, great. You know, we've got a nice sign that's telling us it's probably not raised intracranial pressure. However, if you don't see it, can you make any conclusions? And the answer is you really can't, because a good chunk of patients don't have spontaneous venous pulsation unless you've documented it before. They had it last year and now they don't have it this year. So really that's what you've got to, that's how we differentiate when it comes to SVP. Now, in my clinical experience, when you're looking at that nerve, kind of like, you know, let's go back to, I'm going to go back to mini case number one here. There we go. Here's mini case number one. Remember, this was that 28-year-old female, and we could go either way maybe on this one. Maybe more thought no vessel obscuration, but isn't the 28-year-old overweight female that's got some elevated nerves, that has some headaches, and you're going, great. 28-year-old overweight female, headaches, nerves are elevated, and you're wanting to go, I just need to see some SVP. Do you ever see SVP in this patient? It's like never. This is the one you never see SVP in this patient. So, you know, is it useful? It can be. If it's there, great. Now, again, this is why I like the chat box. Dr. Nancy had a patient with SVP and a brain tumor. 18-year-old white male, just had his third surgery. So again, nice little pearl on that one. Again, there's no steadfast rule in anything in medicine, but by and large, if they see SVP, that's a good sign, but there certainly can be exceptions to that as well. Can you have absence of a previously noted SVP without any other signs and symptoms? So they had an SVP before, and now they don't have it at all. It's basically went away, no other signs and symptoms. You know, that's a good question. I don't know that I have any strong answers on that one, where you saw SVP before and now you're not seeing it in an asymptomatic patient, no signs, no symptoms. Would that trigger me to do anything? Probably not. I mean, if their vision is great and their pupils are great and the front of the eye looks great and the back of the eye looks great, you know, OCT looks great, visual field looks great. If everything else, signs and symptoms, could you develop that? I'm not sure why you would develop a loss of SVP with everything else normal, other than maybe you just missed it before. Or maybe you saw it before and now you're just missing it now. That would be the best answer I could give on that one there. So SVP, is it useful? It can be. There are times where it doesn't have much use as well, but you should look for when differentiating true swelling from pseudo swelling. How about the OCT? That's a good point, Dr. Greg. You know, did that patient, Dr. Nancy, did they have optic nerve head edema? Because certainly if they didn't have any optic nerve head edema, you can have brain tumors that don't cause optic nerve head swelling, that don't cause significantly raised intracranial pressure. So that could be the reason they have SVP. But if they've got significantly swollen nerves from papilledema, I would like to think there likely wouldn't be SVP there. But again, I'm never going to say never when it comes to medicine. So OCT, second thing, you grabbed your 90 diopter and your 78 diopter lens, grab your OCT or have your technician do an OCT. And there's a couple of things that I like to look at when it comes to an OCT. Number one is let's just get an RNFL thickness. You know, we all know what a normal RNFL thickness is. This is my OCT from a number of years ago. When you scan a patient in their teens, 20s, 30s, 40s, 50s, what is the overall average RNFL number? It's usually somewhere between like 85 and 110. And you can see I'm at 105 in the right eye and 102 in the left eye. That's normally where you're going to be. You've got your normal quadrant analysis here, your clock hour analysis as well. Again, these are very normal numbers, no issues in this OCT, but it just shows you what normal is. In a patient with true swelling, whether it's from papilledema, IIH, or something else, oftentimes this number is going to be elevated. Let me show you the extreme example. Here is a patient with IIH, drastically swollen optic nerves that you can see here and here. And you notice we're at 458 in the right eye and 285 in the left eye. Now, obviously, we didn't need the OCT to diagnose this, but it drives home the point that if you're looking at the nerves and you go, you know, they're elevated, the margins are indistinct, I'm trying to differentiate true swelling from pseudo swelling, true swelling from pseudo swelling. Is this, the vessels aren't telling me a whole lot, the SVP is not telling me a whole lot, grab your OCT. And if you see numbers like this, to me, this is tipping you down the road of maybe it's less likely to be swollen. But if you see numbers in the 150s and 160s and 170s and 180s, again, not 458, but if you see numbers that are out of the normal ranges that we see on a day in and day out basis, maybe that's tipping you more towards maybe there is some swelling or some subtle swelling in this case. Again, here's the drastic, the obvious. Here's another one, 253 in the right eye, 227 in the left eye. Didn't need the OCT to see this as monstrous swelling in both eyes. But maybe it's more of a case like this, where again, the margins are a little bit indistinct. Is there vessel obscuration, plus, minus, don't know. And the OCT is at 154 and 141. Again, I'd be curious to get your comments via the chat box, or Greg and Joe, if you want to chime in as well, is I don't see a lot of what I would call normals without any pathology in the 150s, 160s, 170s. So if I see this, I go, why is that 154? Why is that 141, especially in a patient that's borderline? Maybe they've got symptoms. There's a reason I'm doing the OCT here, and it comes back this would push me towards maybe there is some swelling in this case. I don't see a lot of normals in this area. Do you guys, via the chat box, do you see normals in the 150s, 160s, 170s? If the nerve is elevated, not swollen, would the RNFL be normal?
Well, there's actually another number we can look at, and when looking at pseudo swelling versus true swelling, the first thing we have to try to differentiate, or the most common is it disc drusen? And a study came out a few years ago that it doesn't matter what OCT that you look at. If you look at the nasal thickness, okay, nasal thickness greater than 88 microns is more associated with optic disc edema than it is optic disc drusen. So caveat is you can have early disc edema and it can be under 88. But once you go above 88, that is more commonly found in disc edema than it is in disc drusen. That's nasal thickness. Yep. And you can see it on your quadrant or even your clock hour on this. And that, I think, is something that is very easy to remember.
That's a great pearl, Joe. That's right. Actually, right. We were going to mention that in just a couple of slides here. If you can, right on this slide, and you notice that 112 and 101 here, that certainly is another reason that it's pointing us down. There's probably, or at least pointing me down, there is some swelling on that. So great pearl. There's Joe. Obviously, these ones are way above that and way above that as well in these cases. So I do look at the overall number, do look at that nasal quadrant number as well, greater than 88, as Joe just mentioned right there. So again, disc drusen, in my experience, disc drusen is not going to hike up those numbers. It's much more likely that it actually could take it the other way, and it could cause thinning of that OCT as well. So again, go back to those numbers that we discussed. Get an OCT, a quantitative OCT, look at those numbers and see what they're showing you. I also like to get a qualitative OCT. Get a 5-line raster. Again, there's no numbers associated with this OCT, but take a look at that. And are you seeing any fluid? Are you seeing any edema located along the disc margins, the disc edges? Is there a V sign, which we'll talk about in just a little bit? This is the classic or quintessential case of optic disc drusen here. And if you look at the various literature, various studies, it will describe what's called a bumpy internal contour. As you can see or follow along, some of these are vessels here as well, but this internal contour, you can see we're kind of up and down and up and down and up and down. And is this, optic disc drusen creating these channels here? And really, as you see right at the margins here and here, we're not seeing any fluid. We're not seeing any separation of retinal layers here. The classic or quintessential appearance of optic disc drusen in this case right here. Here's, again, a nice OCT from the literature, from the study, showing, again, maybe another bumpy internal contour, kind of an up and down and up and down. Top OCT, a representation of an elevated but non-swollen nerve in a case of optic disc drusen, versus the bottom one. There's been studies that have described what the V sign, basically a splitting of those retinal layers right here. Drusen shouldn't cause that. Small disc shouldn't cause that. Tilted disc shouldn't cause that. This splitting of those layers there, that's likely pointing you strongly down the road of a truly swollen optic nerve. It's really one of the pathognomonic signs of a truly swollen optic nerve. Pathognomonic meaning if you see it, it's likely a true swelling. If you don't see it, it doesn't mean it's not swollen. So, I mean, you can have non-V sign optic nerves where you're not seeing it on the OCT and yet the nerve is still swollen. But if you see it, very, very likely that nerve has some true swelling and it's not pseudo-swelling. Here's a case that we saw, very elevated optic nerves. You can see a classic, look at that separation of retinal layers, separation of those layers right there as well. We've got the V sign on both sides in one eye and the V sign on both sides of the other eye as well. Again, these nerves were probably so obvious it didn't require this OCT, but just driving home the point of that OCT as well. So again, OCT can help differentiate, get a quantitative analysis, the overall number and the nasal quadrant number as well, and then get a qualitative. Just take a look at the nerve. What's it look like with a 5-line raster? If it looks like this, I'm feeling better, feeling much, much better about this OCT. Obviously, if it looks like this, I'm not feeling as good, and this is much more likely a truly swollen nerve. So let's go back to mini case number 1. You guys remember this mini case number 1, 28-year-old female. She's a headache person. First time that you had seen her. I forgot to tell you a little bit about her history. 28-year-old female. She's a headache person. And she told, remember, it's the first time you've seen her. Hey, doc, by the way, when I was 16 years old, I was poked in the back. I remember being poked in the, I had headaches. I saw the eye doctor. They sent me for this special testing. I know I got MRIs, but man, I also got poked in the back. That sucked. That was no fun at all. So, you know, she's had a lumbar puncture at some point. And you can see that on this photo here. Again, we kind of went, is there vessel obscuration? Is there not? Yes or no on this one. 75% of you were leaning no. 25% of you were leaning yes. There was no SVP. Well, let's get an OCT on this one as well. And here's the OCT. So I'm going to ask you via the OCT or via the chat box now. You're looking at this via the chat box. Does this make you feel better or worse? Better or worse in this case right here via the chat box? You got, again, this 28-year-old female. She's got poked in the back. She's got headaches. She's got somewhat suspicious looking optic nerves. Vessel obscuration, 75% of you were leaning no, that made you feel better, but 25% of you said maybe yes. SVP didn't help. And this is better, 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 better. You guys can see, again, our numbers here, 104 and 107. Here's where I usually make the point of that nasal, as Joe said here, right there. That's making us feel better as well. So that makes me feel better. How about the qualitative? Here's the qualitative OCT. And you take a look at the right eye and the left eye and the qualitative OCTs. Again, once again, better or worse on the qualitative OCTs. What do you think via the chat box? And it's going to match the answers from before, correct? Better, 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 as we've talked about. So do I think anything is going on in this case? No, I think she's probably had some papilledema at some point way back. She got poked in the back. She probably had pseudotumor cerebri or IIH in the past. Nothing acute, nothing active at this point in time in mini case number 1. How about mini case number 2? In mini case number 2 here, again, this was where we were about 50-50 on the vessel obscuration. This was the 22, 23-year-old completely asymptomatic male, completely asymptomatic, just in for a general routine exam, 2020 or 2015. There was the back of the right eye and the back of the left eye. Again, we were 50-50 on vessel obscuration or no vessel obscuration. SVP didn't help in this case. Here is the OCTs. And again, looking at this quantitative OCT, better or worse? What do you think on this one? Better or worse on this OCT? And again, I go, shoot, this is why I asked this question and going, I don't see this in normals. You know, I don't see 146 and 157 in normals, making all of you feel worse. Look at that nasal quadrant, 101 and 117. It's So it just kind of leaves you as a head scratcher going asymptomatic, 2015, pupils look normal, even though it looks maybe potentially bilateral. Vessel obscuration, maybe yes, maybe no in this case. This one, we watched this closely. We got a clean neuroimaging in this case. It's a healthy 22, 23-year-old male. So again, sometimes we have these cases that are head scratchers. I don't usually see normals in this range. Maybe this is the exception. I don't know, but I think the bottom line point on this is this OCT made me feel worse, the quantitative. How about the qualitative? We took a look at the qualitative OCT. And again, sometimes all of our findings just don't always make sense. The qualitative, there's the right eye and there's the left eye in this OCT right here. One last question on mini case number 2, better or worse for the qualitative OCTs right here and right here. And now we're leaning towards better, and it's like, it's interesting on this of one OCT made us feel better, one OCT made us feel worse. I always go back to one of my great colleagues. He was actually the dean at Pacific University when I started there in 2005, Dr. Lee Carr. Brilliant man, brilliant clinician, taught our neuro course, just a brilliant diagnostician. And he always had a saying, bad neuro gets worse. Those cases where you're really questionable and man, they're asymptomatic, but these other signs are kind of making me nervous, like this one right here. Educate, watch closely. Bad neuro gets worse, or at least bad neuro tends to get worse. So you can watch this very, very closely. Now, if your patient says, well, I sued the last doctor that watched me and missed the diagnosis, well, obviously I'm not going to watch that one. I'm going to send that on. But, bad neuro gets worse. This patient never got worse, never progressed, never changed in this case whatsoever. So maybe these OCTs were more indicative. I'm looking at the chat box here. Great to see the optic nerve and the vitreous interface interaction. Pending PVDs can cause thicker numbers. It's exactly right. Great pearl from Dr. Greg as well. That's why I love this interaction. Love interacting with these guys because you've got 2 experts on there as well. So the quantitative and the qualitative, nice to pair together when it comes to your OCT. So take a look at the nerve. Are the vessels blurred? Is there SVP? Look at the OCT as well. Now, how about symptoms? I want to drive home symptoms with this quick case right here. I'm not going to show you guys anything other than give you symptoms. 28-year-old African-American female. 28-year-old African-American female comes in for this reason. Doc, I lost my vision 4 days ago. Woke up that way. All right. Lost my vision 4 days ago. I just woke up and man, I cannot see anything in that right eye, doc. No problems in the left eye. This is a unilateral problem. It's been going on for 4 days. Yeah, you've lost some vision. Hand motion in the right eye, 20/20 in the left eye. Okay, there's again symptoms wise. Right? Going back, why am I talking symptoms? That can help differentiate true swelling versus pseudo swelling. Just based on what I've given you, just that. The quick history in the vision, is this true swelling or pseudo swelling? True or pseudo swelling based on these symptoms? If that's all I've given you, all I've given you is of course, this is true swelling based on the symptoms right there. So what caused this? We've got an APD in the right eye. So our hand motion for 4 days, APD in the right eye, anterior segment looks normal and posterior segment looks normal as well. If that's the only information that I've given you, you know the age, you know the gender, you know the demographics, you know the history. What is your likely diagnosis? What's the number one differential just based on everything I've given you right here? And you guys look here and you go optic neuritis, retrobulbar, MS, posterior optic neuritis, refer out. Again, certainly you could refer this patient out if you desired as well. Something is going on and you guys are all leaning towards some sort of optic neuritis, retrobulbar, maybe MS. I think that's a smart, and it drives home the point that didn't symptoms leave you right towards that. What did this ultimate being? Is ready? There's the MRI, the orbits with and without contrast, 28-year-old female, and you take a look at this, and what did we have? We had acute optic neuritis, impression, multiple sclerosis in this case right there. Again, it drives home the point that symptoms certainly can play a part and play a role in helping to make our diagnosis. And which road are we going to go down? Pseudoswelling, papilledema, or one of the 3 eyes and the 3 T's as well in that case right there. So remember your symptoms. Obviously, remember your history. That was part of the history as well. And B-scan, B-scan, drusen, you could utilize this. Now, with the advent of, OCT and the variety of things that we can do with OCT and our other imaging techniques, do I use the B-scan a whole lot? I don't, but it's a tool that we can still use and take a look. And are we seeing drusen? Are we seeing signs of that on the B scan as well right there? Joe, Greg, I would get your guys' thoughts. You guys utilize B scans a lot in these patients? Every case that you see, you guys have any thoughts on the B scan?
Well, before we go into that, the last case, I want to ask you, did the patient have painful vision loss?
Say again?
Did the patient have painful vision loss?
The patient did have painful vision loss, which you meaning pain and eye movements. They had that as well. Yes.
Okay. I don't use a B scan very often at this point. In the current practice I'm in, it's kind of hard to get that done.
Yeah, and that's exactly what our experience. We're at a school, so we have one at a school, but we've used it less and less as the time goes on, just from the variety of other imaging modalities that we have. But again, back to your swelling, pseudo-swelling, the ways to differentiate. We went through most of these at this point in time. So let's get to a little bit bigger case. It's not a mini case, a little longer case on true swelling versus pseudo-swelling. This is a 12-year-old male in for an annual eye exam, no complaints, no concerns, asymptomatic. I actually didn't see this patient. One of my colleagues, good friends, former students practicing in Kansas saw this patient, called me up, texted me, emailed me the images and said, hey, I got a patient in a chair, want to get your thoughts and help on this case as well. 12-year-old male, no complaints, no concerns, long-standing alternating esotrope plus 325, vision's 20/20. So our vision is good. Again, we've got no problems, at least we think, at this point in time. There's the back of the right eye. And the back of the, give you just a couple of seconds, back of the right eye, back of the left eye. This is the opening image of this lecture. After we did all the fun pictures and things like that, this is the opening image of the swollen optic nerves here. This is the left eye of this 12-year-old asymptomatic male. So certainly, if you look at this, obviously these nerves, the margins look indistinct. I will tell you that the nerves looked elevated based on the doctor that was seeing this patient. Do you, which eye looks worse, by the way, right eye or left eye? Which eye concerns you just based on the appearance, right eye or left eye? There's the right eye here. Most of it's the left eye. So my next question via the chat box is going to be, is there blood vessel obscuration? Yes or no? Blood vessel obscuration, yes or no, in this asymptomatic 12-year-old male? What do you think? And we've got a lot of yes, 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 yeah. And I would tend to agree. You look and going, look here, this vessel right here, going, boy, that sure is a lot of obscured portions of the blood vessel, blurred part of the blood vessel right here as well. Worse in the left eye compared to the right eye. So that certainly is making us concerned in this case right here. Was there SVP? Isn't this the case that you want to see boom, 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 boom? And there was no SVP in this case. Doesn't really contribute for this patient here. Here's the OCTs, quantitative OCTs. You take a look. This patient, we've got no normative or reference database because of the age in this particular male patient. Overall number, 153. As you can see here, we break it down based on the quadrant analysis. Nasal, 126. As you can see there, there's the right eye and there's the left eye. Notice the same overall number, 153. Nasal's now 191 in this case as well. So we've got OCTs quantitatively, and here's the qualitative OCTs. Again, you guys thought the left eye looked worse than the right. You take a look at the qualitative OCTs, and certainly you can see the left eye looks more elevated than the right eye, but asymptomatic. We're a 12-year-old male, we're 20/20, no pupil issues, vision's good, no headaches, nothing in the systemic history whatsoever. So I'm going to ask you now, this is via poll everywhere, so we can see exactly what percentage of you leaning pseudo-swelling or true swelling. So what do you think? In this asymptomatic 12-year-old male that's 2020 plus, what do you think? Which way are you tipping? Which way are you tipping? Is it pseudo swelling or is this true swelling? Let's try to get 30 to 40 answers here in this case. So you guys can see the exact breakdown. I did forget to mention that these questions are not required to get your credit. If you're doing this for CE credit, not required, encouraged to do, so we can see the breakdown of answers. What do you think? Pseudo swelling A or pseudo swelling B? And we've got some answers coming in here, again, via the poll everywhere. POLLEV.com, POLLEV.com/Nate Lighthizer. And all right, we've got a good smattering of responses. Let's see what you guys are thinking here. Okay, I love it. And actually, it's different on the chat box. We've got 1, 2, 3, 80. There's 4 A's and 1 B via the chat box. And so we're leaning more towards pseudo. So when you add these answers together, we are probably pretty darn close to 50-50 because there was 4 A's and 1 B on that there. So again, I love the answers on this one. Here's what I told again, it was one of my former students, colleagues, and friends. Here's my recommendation. Going, I would refer this out to a pediatric or a more likely a neuro-ophthalmologist for a second opinion. I'm not overly concerned because I go back to the Dr. Carr saying bad neuro gets worse and we're asymptomatic. These OCTs actually, I was like, okay, I'm not seeing any. That's kind of not great pictures, but is there a V sign here or not? Hard to say. The doc didn't think so when looking at that. This concerns me going, okay, why are we 153 and 191 nasally? And same thing here, 153 and 126 nasally, as we talked about. The disc appearance concern, but again, asymptomatic. We're not overweight. We have no headache history. We have no other systemic symptoms at this point in time. So that was my recommendation going, I think that there's maybe some swelling here, but I'm not concerned because I can't figure out what's going on at this point. Let's get a second opinion in this case. So they sent it to a local pediatric ophthalmologist, and the pediatric ophthalmologist diagnosis was pseudopapilledema. So he agreed with approximately 45-50% of you that put pseudo swelling. And this was a treatment plan. Monitor and see back in 4 to 6 weeks to monitor for any changes, monitor for stability. Bad neuro gets worse. Let's watch this closely. If you're comfortable with that, if the patient's comfortable with that, that's what we can do together. If anything changes systemically, eye-wise, vision loss, anything, color vision changes, something you're perceiving differences in their vision, come back sooner. Otherwise, let's see in about a month, 6 weeks, and see if anything changes. That's what the ophthalmologist did in this case right there. Joe, Greg, you have any thoughts on that? Agree, disagree with the ophthalmologist?
Now, my caveat here is if you're going to do this, make sure you take photographs, because in 6 weeks, you're not going to remember any of the subtle details other than, hey, it looked like this before.
Yep.
Now, maybe if they come back and it's hemorrhagic or there are signs of ischemia, all right, then you can make a difference. But you really need to take photographs, good fundus photos, if you're going to be doing something like that.
Yep. Joe, would you have attempted a visual field in this 12-year-old?
Sure.
Yep, I would as well. I recommended a visual field. Take photos every visit, OCT every visit, so you can see, are the numbers changing? Do we have stability in this case? Again, ultimately, this never changed. It stayed stable. The former student kept me up to date on this, and they just kept watching this, and it just hung out just like that for a long, long time. And this, again, our case number one, our larger case number one. All right, so let's go on to,
just to add something here, Nate.
Yep.
It's very important that we do for these patients what we do. We're eye doctors, we do eye examinations. Now, if this ends up with a pediatric neurologist, a neurologist, somewhere else, these tests aren't going to be done. And if you're not sure, I'm not talking about the champagne cork into the vitreous, but if you're not sure, that means that you've got a little time to think about this. Get color vision, pupil testing, visual fields, OCT, good acuity, maybe a B scan. You know, these are all things, these are the things that we do that if we don't do it here, downstream, it may not get done. So don't panic. You know, I've always said, if you're not sure, that means you've got a little time to get a few tests done.
So you would agree with the bad neuro gets worse, right? Watch it closely at the first sign of changing, then you would maybe intervene. I was with an ophthalmologist, very prominent, one of the biggest names in ophthalmology at Seco. We had a meeting right at the end of the meeting, rode to the airport together and chatted with him for a number of times. And he said, you know, one of the things that I would encourage optometry to do more of is make a call. You know, make your diagnosis. This is what you think based on your expertise, your knowledge, your testing, again, whether it's visual field, color vision, pupils, photos, your examination, make a call. And because ophthalmology does that all the time, they make a call, you follow it closely, appropriate intervals of follow-up, and then you can change your course of treatment, your course of action based on more information that you get at those follow-up visits. So never be afraid and trust your medical judgment. Make a call, have the appropriate follow-up, and you can change it. If you go, you know what, I don't think this is anything, and I'm going to follow this closely, and whoops, 2 weeks later, 3 weeks later, 4 weeks later, you're seeing a change in the photos or a change in the OCT. Now you can go ahead and refer to the appropriate specialist at that point. So make a call. You guys are experts. Trust your judgment. Obviously, if you're not comfortable with something, you can go ahead and send that off. But you guys trust your knowledge and wisdom in testing and follow them closely, as Joe so nicely put it as well. All right, so that was our true swelling versus pseudo swelling case. Let's go into case number one. A 29-year-old female comes in with headaches. I actually saw this patient with a neuro-ophthalmologist a number of years ago, 29-year-old female. And I remember sitting in the office with a neuro-ophthalmologist during my residency, and the phone rang at the end of the day, and it was another provider in another part of the hospital that said, hey, I've got a patient there with these weird visual things going on. Again, this is not an eye doctor. This is another doctor in another part of the hospital saying, hey, we've got a patient here that I'm going to send down to you. End of the day. And she's been having headaches for the last 6 to 8 weeks, worse in the morning, worse when changing positions. But she's having these kind of weird gray outs in vision. She describes it as like a piece of wax paper dipped in front of her eyes for just a few seconds, and then it's better. And then she might go a few hours and everything's okay. And then the wax paper is back right in front of the eyes. Oh man, it's gray out in vision. And then it's better again. So it's these transient short-term gray outs in vision along with these headaches in a 29-year-old female. Personal medical history was unremarkable. No medication use whatsoever. When she got down to the office, she's 20/20 in the right eye and 20/20 in the left eye. So obviously we're not having those gray outs in vision at this point in time. Pupils were normal, EOMs were normal when we took a look at the entrance skills testing. Here's the back of the right eye. Take a look at the back of the right eye. We'll give you a couple of seconds on this one. Back of the right eye and back of the left eye. Back of the right eye, back of the left eye. Once again, 29-year-old female. I will tell you she was about 5'5", about 200 pounds. So the body mass index was elevated. We've got these headaches for the last 6 to 8 weeks. The nerves are certainly elevated. Do you see blood vessel obscuration? Yes or no? What are your thoughts via the chat box? Blood vessel obscuration, yes or no? Into blood vessel obscuration in this one here. And we've got most of you saying yes. We got a lot of yeses, a couple of no's in there, but a lot of yeses on this one here. Was there SVP? Do you think there was SVP in this case? And the answer was no. There was no spontaneous venous pulsation. Here is a magnified view of the optic nerve heads. I would certainly agree with the majority of you saying, yeah, it looks like there's blood vessel obscuration or blurriness in this case. This is an older case. They had an HRT at the time. This is just showing the elevation of those optic nerves. And here's the visual field. Visual field, as you can see here, left eye is on the left, right eye is on the right. So I kind of put it backwards, showing enlarged blind spots. And we got some peripheral scattered defects as well in this case. So we've got visual field showing enlarged blind spots in both eyes here. So here's my question for you. And I forgot to mention this is when I was sitting there with the doctor while he was on the phone, the neuro-ophthalmologist, he looked over at me, he said, there's a piece of information in this patient's demographics that's likely giving away the diagnosis. Which piece of this most likely fits with what you've seen thus far? Which one piece of information here? Does she have a family history of optic nerve disease? Is she overweight? Does she have diabetes? Does she have malignant hypertension? Or does she have multiple sclerosis? Which one of these is the most likely thing that we are going to find in this 29-year-old female with a picture that you just saw here? Again, visual fields that show enlarged blind spots. There's our optic nerve in the right eye and optic nerve in the left eye. Which one piece of data is most likely going to fit with this case? Optic nerve disease, family history. Is she overweight? Does she have diabetes? Does she have malignant hypertension? Or does she have multiple sclerosis? Again, probably doesn't have multiple sclerosis. We just talked about a case with history. Most cases of multiple sclerosis that have an optic neuritis, it can be retrobulbar. Even if it's not retrobulbar, they're almost always unilateral with reduced vision, painful vision, APD. We don't have any of that in this case, so it's probably not multiple sclerosis. Diabetes, malignant hypertension, she had nothing in her history. Should you check blood pressure? In every case of a swollen optic nerve, I believe you should. You should be checking blood pressure. What fits best in this case? Yeah, is she overweight? And I told you she already had an elevated body mass index, which she did. So that leads us to a diagnosis of pseudotumor cerebri, better known as IIH, or idiopathic intracranial hypertension. So which test, here's my last question on this case, or at least in the diagnosis of this case, which test should be done first to aid in the diagnosis? If you're suspecting papilledema from IIH, should we do an MRI and an MRV, CT scan, lumbar puncture, or a carotid ultrasound? Wait, what should be done first to aid in this diagnosis? And I remember the ophthalmologist, he asked me, what should we do? I said, I think we've got pseudotumor cerebri, which is, we called it more of that at the time when I saw this patient, but we got pseudotumor cerebri, IIH, it's papilledema, it's elevated head pressure. We should do a lumbar puncture. And he looked at me, he said, do you want to kill the patient? I said, well, no, that was week one, or maybe even day one of optometry schools. Don't blind or kill your patient. I said, we have elevated head pressure. We've got papilledema. We need to do a lumbar puncture. And he said, yes, that's likely what we have, but that is a diagnosis of exclusion, and we need to rule out other things first. So he was always very big on, and get great answers here, the majority putting lumbar puncture, but I would argue that the most correct answer is neuroimaging. And he was very big on an MRI and an MRV. We need to rule out other things, as we'll talk about in just a second. So you really want to do the neuroimaging first. He always said, this is a 29-year-old overweight female, and it's most likely that her papilledema is from IIH, or pseudotumor cerebri. A 29-year-old overweight female with a brainstem tumor. And if she's got a tumor in just the wrong location and a lumbar puncture is done, that could cause brainstem herniation and kill the patient. So neuroimaging really is indicated first. Lean on your MRI. And he always recommended an MRV as well, to look for something called venous sinus thrombosis. Is the lumbar puncture then indicated? Certainly, it's indicated as well once the MRI and the MRV come back normal in that particular case. So MRI and MRV were unremarkable. In that case, lumbar puncture showed an elevated opening pressure of 332 millimeters of water. You could also, I've seen that labeled in centimeters of water as well, which would be 33.2 in this case, normal CSF composition. And that led to the diagnosis of pseudotumor cerebri in this particular case. Treatment-wise, weight loss, oral acetazolamide or Diamox, 500 milligrams by mouth twice a day. That's surgeon or ophthalmologist. He was a neuro-ophthalmologist. Always up that to 3 or 4 times a day of the Diamox if the patient could so tolerate the potential adverse events with oral acetazolamide or Diamox. So that was our treatment plan in this case. Follow-up. Wouldn't that show up in the MRI, larger ventricles? That's interesting. I think it probably could. In this case, it didn't. In my experience, that doesn't always show up that way. And in this case, it did not. The MRI and the MRV were unremarkable in this particular case. Could it? Yes. In this case, it did not. So I want to ask you guys via the chat box. You just saw this patient, 29-year-old female, that's got pretty significantly swollen optic nerves. Joe and Greg, I'm going to throw this one to you guys again real quick on this. Anything that you see in these nerves that are particularly striking to you? Any thoughts on that?
Well, it looks as though there's some sort of irregular or abnormal vitreal interface attached to the optic nerve in this one.
Yep. We call this high. So somebody call them high watermarks, Patton's lines. You use that term, Joe and Greg. Patton's lines. These pathognomonic kind of circles or high watermarks. Do you guys use those terms?
I do, but I am more familiar with actually saying not so much like this, but the. Well, I'm gonna mute somebody.
Yeah, somebody. Dr. Chauvelin mentioned Pattons, and that's what we call them as well. And I was trained that those are one of the pathognomonic signs that you can see, that if you see something like that, boy, you've truly got swelling there, and it was pretty obvious in this case.
But it's typically multiple folds, almost like choroidal folds from the emanating from the temporal aspect of the disc. It usually isn't quite as circumlinear as what you showed there.
Yeah, it's interesting how this is presented in both eyes, isn't it? All right, so that was our diagnosis. We talked about that. When via the chat box, I'd be curious with you guys via the chat box, if this was your patient, case number 1, 29-year-old female, you've seen the visual fields. There's the visual fields. You've seen the nerves. You know her symptom history. She's 20/20, no pupil issues. She's had headaches and these weird grayouts and visions for the last 6 to 8 weeks. When would you see this patient back? Let's say you're going to treat this. You're going to talk to this patient about weight loss, and you're going to start this patient on oral acetazolamide via the chat box. When would you schedule your first follow-up? When would you see this patient back for their first follow-up? I'd be curious via the chat box. What do you guys think? I want to see a smattering of when you guys would see this back. And we've got 4 to 6 weeks, repeat the visual field, 1 week, 4 weeks, 2 to 3 weeks, 1 week, 1 month, 10 days, 1 month, 2 weeks, 2 weeks, 4 to 6 weeks. Again, I just like you guys to see most of you are going to see this patient somewhere between 2 weeks and 6 weeks, somewhere in there. We saw this patient back in 1 month. We're going to see you back and really follow you about every month or so. Are your symptoms okay? How's the visual field doing? I agree completely with the first answer we saw via the chat box. I'm going to see you back in 4 to 6 weeks, and we're going to repeat that visual field. Take those pictures again, as Joe said, OCT as well, looking at those numbers or that quantitative OCT. So we did that month after month after month. How you doing? Any adverse events from the Diamox? 6 months later, again, this is over the course of multiple visits. We saw this patient about every month. 6 months later, she said, you know what? Headaches are gone. Visual problems, they're much better. She had lost 20 pounds, which was good. And she had near total resolution of the papilledema. SVP was present. The visual field went from this, the day that I saw her, the very first visit. And 6 months later, her visual field showed this. So her visual field was moving in the right direction, as you can see from this to that one right there. Her HRT went from this down to this as well. So certainly that was improving as well. And you can see the appearance of her nerves. They were certainly improving as well with those patterns or high watermarks. They were improving as well in this particular case. So see them month after month after month. Make sure things are not progressing or getting worse. And things went very, very well. Question is, Topamax added for weight loss? Yes or no? In this particular case, Topamax was not added for weight loss in this particular case. This case was seen about a decade ago. So it was weight loss and Diamox. Those are the two main treatment options in this case right there. Certainly Topamax could be used as it's now a medication that can be used off-label for weight loss there. So pseudotumor cerebri, or idiopathic intracranial hypertension, or IIH. Elevated intracranial pressure. Again, it's kind of like glaucoma. It's usually more of a drainage issue than it is a increased production issue. It's not they're producing more and more of this fluid. It's probably a drainage issue or decreased absorption, I should say, when it comes to IIH or pseudotumor cerebri. Again, I like IIH or benign intracranial hypertension because when you say pseudotumor cerebri, a patient hears, I've got a tumor, and you've got to explain all of that as well. No, it's mimicking a tumor. It can cause symptoms and signs like a tumor, but it's not a tumor, hence the pseudo tumor. Etiology, idiopathic. Again, usually young, overweight females. Interestingly enough, and I had never heard of this before I was with that neuro-ophthalmologist for a period of time, that young females in their teenage years, 20s, and 30s, weight is very much a link between those patients. However, if you ever see a patient at age 12 or under the age of 12, the gender link and the age link are not nearly as strong. Strong link between gender and weight in the in teens, 20s, 30s. Female much more likely, weight often indicated as well. You get under the age of 12, the gender link and the weight link are much less likely. So you're just as likely, according to, again, this ophthalmologist, that of seeing an 8-year-old skinny male as an 11-year-old overweight female that has idiopathic intracranial hypertension. So if you ever see those younger patients, 12 and under approximately, remember that the age, or not just in the age, the weight and the gender not as strongly linked as the normal patients we see with IIH. Certainly medications can cause this. You can have, again, your oral contraceptives, your tetracycline, specifically doxycycline, minocycline, especially too much vitamin A as well. Looking at a question here. If you had a normal MRI and MRV, could you potentially start Diamox without getting the lumbar puncture? That's not typically how I do. Could you do that and save yourself a patient of a lumbar puncture? Yes, I do believe that most likely that you really should, to confirm that we do indeed have elevated intracranial pressure and therefore pseudotumor cerebri or IIH. We've got papilledema in that particular case. So normal MRI, normal MRV, I still do want to see that lumbar puncture. Does it have normal composition? That's important as well. And is that pressure elevated? Yeah, we do have papilledema in that particular case. So I would still want to get that. I've heard of others not doing it, but that's how I tend to practice, is I still want that lumbar puncture. Don't forget the medications. Again, the oral contraceptives, tetracycline, doxycycline, minocycline, and high doses of vitamin A as well. Symptom-wise, indications for a lumboperitoneal shunt. We'll get there in just a little bit. Symptom-wise, headaches, visual disturbances, two most common. Again, the vast majority of those patients, again, have headaches, often worse in the morning, worse with changing positions as well. Again, those headaches, not all of them, but boy, the vast majority of patients are going to complain of worsening headaches, changing positions, worse in the morning as well. But then don't forget about those transient visual obscurations, the TVOs, the grayouts in vision. I've had patients describe it as, boy, it's like a downpour of rain on the windshield and I can't see anything. Imagine if your windshield wipers weren't working and it's just pouring rain. Yeah, you can vaguely see out there. It's not a blackout, but you can't see very well at all. So again, windshield wipers not working in a heavy rain, wax paper in front of their vision, gray out in vision, these transient visual obscurations. Again, about 3/4 of patients will complain of those. And then there's a variety of symptoms that can happen. They're not in the majority, from ringing in the ears to diplopia, which is usually a horizontal diplopia in these cases. Again, pretty rare to see a lot of these other stuff like abnormal color vision. Signs, we've already covered this: papilledema, hallmark of pseudotumor cerebri, bilateral, swollen nerves, secondary to raised intracranial pressure, at least asymmetric swollen nerves. It's usually in both eyes. It could be asymmetric. That's our papilledema. Again, the disc edema, the blurred disc margins, the obscuration of the vessels, hyperemia. You can get venous dilation. You can get hemorrhages, cotton wool spots. There's the patents or high watermarks as well when it comes to pseudotumor cerebri. We had a lot of these different signs, as you can see here, in this case, of pretty classic papilledema in this case right here. Can you get in a large blind spot? Sure. You saw it in this case right here: sixth nerve palsy, elevated head pressure, long course of that sixth nerve, pushing down, pressure on that causes a sixth nerve palsy, horizontal diplopia. By definition, that's actually, when you talk about pseudotumor IIH, that's really the only neurologic symptom other than the papilledema. You've got papilledema, you've got a potential fairly rare sixth nerve palsy. Other than that, you really shouldn't have any other neurologic signs or symptoms like tingling, the numbness, the slurred speech. That's all signs of other things going on. Neurologically speaking, it's a 6-nerve palsy. It's papilledema. Other than that, you don't have a whole lot of neurological stuff in this case. Diagnosis of exclusion: intracranial tumor, mass, bleed, hydrocephalus, venous sinus thrombosis. That's the reason for the MRV. And then usually you settle on a diagnosis of IIH, or benign intracranial hypertension in that case. Diagnosis: clean MRI in MRV. Lumbar puncture, as we've talked about already. No other neurological findings. SVP, you hope you see it. You often don't, as we've talked about already. And that ultimately leads to your diagnosis of idiopathic intracranial hypertension. Which of the following is the best long-term treatment option for pseudotumor cerebri, or IIH? Weight loss, diamoxicetiozolamide, repeated lumbar punctures, or oral prednisone? Best long-term treatment option. Question is, do I recommend or do lab work prior to starting Diamox during the course to ensure no side effects? I usually don't, unless there's a history pointing to that. I don't usually do don't usually do lab work before starting Diamox. Maybe I'm an anomaly on that one, but I usually do not recommend doing lab work prior to starting Diamox, unless I have some sort of history that's indicating for me on that one there. All right, we've got a lot of A's. Another question: if this patient were asymptomatic, do you send the patient to the ER with the order for MRI, MRA urgently, maybe an MRI and an MRV? Is there a non-ER option? It's a good question on that. I've heard this a variety of ways, that when you see a patient that looks like this, this isn't an ocular urgency. This is an urgency or an emergency. And this really should be going right away. I don't know if I totally agree with that it needs to go right away, especially if they were asymptomatic, but I wouldn't disagree with it. I mean, I wouldn't, does it have to go that hour? Some would say yes. Some would say it needs to go right away that day. Bottom line, it needs to go sooner rather than later. I mean, this is not a next week thing. This is a today or tomorrow or the next day. As soon as you possibly can, this needs to go. So that's how I would answer that one. Ideally, yes, I want an MRI and an MRV on an urgent basis, ideally today or within the next 24 to 48 hours. Urgent care, work with their doctor, depending on the individual circumstance in that case right there. So, let's go back to the question. What was the best long-term treatment option? I'm sure you guys, it's weight loss. Weight loss is the best long-term treatment option, as you can see right here. And interestingly enough, the literature shows it doesn't have to be a great deal of weight loss, as little as like 6%, according to some studies. You talk to a patient about weight loss, that's a sensitive topic. And, somebody that weighs 220, 240, whatever it is, that if you tell them, well, I need you to lose 80 pounds, it's like a mountain to climb in that case. But if it's like, all right, you need to lose 15 pounds or 12 pounds or 20 pounds, that's much more of a doable thing in that particular case. And here's why this is important. This patient is 29-year-old female with pretty significant swelling here. I mean, it's pretty significant papilledema in both eyes. What was her visual acuity? 20/20. She was 20/20 in both eyes. So I always tell patients that, fortunately, yes, I know you've been having these grayouts in vision, things like that, but your vision is 20/20 at this point. But here's why we need to take this seriously. That 20/20 today with swelling, if you don't take this seriously and take the medication, and we talk about weight loss and do all these things together, work with their doctor, 20/20 with swelling today could be optic nerve head atrophy with vision loss, not tomorrow, but in the weeks and months following as well. So I educate, even though your vision's good at this point, we need to take this seriously. Weight loss is important. Oral acetazolamide is important as well. 500 milligrams 2 to 4 times a day. Talk about the potential adverse events, the metallic taste, the tingling in your fingers and toes. You can have GI upset. You can get worse. Aplastic anemia is pretty bad on that as well. So you may need to monitor that post-op, or I should say post diagnosis and post-treatment as well. But these treatments are important, the weight loss and the Diamox. When are shunts indicated? think that was Joe's question, going back here. If they've got progressive visual field changes, progressive visual changes, progressive headaches that just aren't going away, could you consider that? I think we could consider that then. My experience is those often can fail. They can have problems with that. Hopefully we don't have to get to that point in these, but to me, it's that progressive nature, whether it's visual acuity, whether it's visual field, whether it's symptom-wise, headaches, etc., when we're going to these patients as well. So, Joe, Greg, any last question or comments that you have on that before we get to case number 2?
Well, the only thing I want to throw in there is we always have to consider about a condition called Fulmin IIH. And this might speak to the urgency of it. And Fulmin IIH is a symptomatic form of the disease where vision loss can be rapidly progressive from onset of signs and symptoms to vision loss can be 4 weeks. So it's not always a quiet little thing. And this is fortunately asymptomatic. We always have to consider there's a subset of IIH called Fulmin IIH with potentially severe vision loss. So you're right, sooner rather than later to the emergency room, get the workup done.
Joe, do you go the same day? Would you agree with that? Or are you okay within 24, 48 hours?
I would say within 24 hours.
Yeah.
If they can't, if they can't arrange it, 24 hours is okay. It isn't quite the same as an aneurysm with third nerve palsy or arteritic anterior ischemic optic neuropathy. But when we look at it, we suspect papilledema. We don't know that there isn't an intracranial bleed, an intracranial infection, an intracranial tumor. So really, we want to send as much information as we can and direct the ER physicians within 24 hours, yes.
When would you have seen this patient here? That was a 29-year-old and pretty classic pseudo tumor. I asked everybody when they would follow up. Again, we did about 4 weeks. When would you see the patient back, Joe, for the first follow-up?
Well, actually, I'm going to be doing it in conjunction with a primary care physician or a neurologist. I will probably, I'm going to let them, because I'm not prescribing furosemide. I'm not prescribing topiramate. I can prescribe Diamox, but I want somebody on board who can fully manage the condition, and I can help. I would see them back in 3 months and 6 months, albeit they're under somebody else's care, to repeat fields and photos. And if they're getting better, I tell them that. If they're getting worse, I communicate with the physicians about that as well.
So as you guys can see, we've had a wide range from 1 week to 4 weeks to 6 weeks to 3 months is what Joe. There's a lot of different ways you can do it, but absolutely this has to be co-managed with their PCP, a neurologist, as we've talked about already. Question is, if you have a patient.
Hey, Nate.
Yeah.
This is Greg, and and Joe, I'm going to take your feedback on this, and Nate, is that we have these patients that come in, and you kind of set them up as a little overweight or bilateral swollen nerves, and we're talking MRIs and we're talking MRVs. Then we have to jump to lumbar puncture. Wouldn't jumping and doing just a blood pressure be one of the first things we want to do?
Absolutely. I mentioned that earlier very briefly, that I believe that every patient that you're looking at that going, what's going on here? Is this truly swollen? Maybe it's bilateral. And I'm thinking, what's going on? Maybe it's unilateral. Is that should be a part of your routine workup is your blood pressure reading as well. Absolutely. I completely agree.
Yeah. I think, at our practice, we routinely take blood pressures, but, I work with a lot of other practices, and, and for whatever reasons, good or bad, it just doesn't work into the workflow. But, don't forget about doing blood pressure on these people.
Every potential swollen nerve should have a blood pressure reading, a blood pressure measurement when you're looking at and evaluating that patient.
And I would rank that up before we start thinking of MRI, MRV.
I 100% agree. Yep,
Okay.
Absolutely.
I just got a consult from one of our local optometrists via text. He sent me the photographs, and the first thing I said is go back and get a blood pressure. And he came back and told me that it was 180 over 140. But there are other signs of ischemia going on in the retina, which really gave truly a malignant hypertension look.
Yep. Question in the chat box: if we have a patient with all testing normal and no symptoms, but the nerve looks possibly elevated, but you can't determine if it's true swelling versus pseudo-swelling, do you always view it as an emergency? The answer for me is that is no. Like those cases that we just saw, again, patient is asymptomatic. Everything that you're doing looks normal. Again, bad neuro gets worse. I don't think it's bad neuro in the first place, but I do not view it as an emergency when you're looking at it going, the nerves look a little bit elevated. I can't tell if it's swelling versus pseudo-swelling. That's a patient where you can follow very closely, educate if you're comfortable with that. It's the cases that look like, again, this, that people would argue, and I would agree, this needs to be evaluated within 24 to 48 hours, if not sooner than that, because this is not a debatable case. This is a case where you're going, all right, they're symptomatic. We've got obvious what looks to be papilledema. We can't confirm that until they have the lumbar puncture. This is where it's an emergency in this case, or an urgency within 24 to 48 hours, if not sooner. That borderline one, again, I think that's where you make your medical decision. And you say, you know what, I'm going to follow this closely. If the patient's comfortable with that and you have that relationship, come back if anything changes, and we'll go from there. All right.
And Nate, I'm just going to throw this real quick in there. We all suffer from these cases, what you just described. And I was working with a top neuro-ophthalmologist named Grant Liu, who's written one of the definitive texts on neuro-ophthalmology. And he said publicly that when he finished his fellowship, he said, I knew I could look at a nerve and tell if there's a dominance or not. And he said, and after I've been in practice for a few years, I realized anybody who says that has not looked at enough nerves, because I really can't tell myself, and I'm a neuro-ophthalmologist.
It's a great point. Great pearl there. I want to get through two quick cases. I think I've got about 10 minutes left here. Case number 2 is a 67-year-old female that came in. She's complaining of a glob of flashing, twinkling lights in the lower part of the right eye for 24 hours. She said, I basically woke up, doc, yesterday morning, and I got a sparkle box in my right eye. It's exactly how she described it. This patient was feisty. She was a spitfire. She goes, I got a sparkle box just below fixation, just below the center of my vision in my right eye, doc. It's been there about 24 hours. I woke up yesterday morning with this sparkle box. My vision's still pretty good. I can notice a little bit worsening in the right eye versus the left eye, but it's mainly this sparkle box. She went to her local optometrist the day that she got that. She said, I didn't do very well on this visual field. I couldn't see parts of the inferior field. And he sent the patient to us for OCT and evaluation as well. She had recent blood work. She denied headaches, diplopia, temporal or scalp pain. You can see her kind of medical history there. Again, she's overall pretty healthy with some osteoarthritis and some migraines. There's her vision. She's 20/20 shaky in that right eye. So vision's not bad in the right eye. Again, down about a line and a half from the left eye. We've got no APD. I thought that was interesting. The student said there's no APD. I went, there's going to be an APD there. I went in there to check, and I didn't detect the APD either. So I'm going to call it no APD. Anterior segment IOP is unremarkable. There's the back of the right eye. Again, this is the eye in question. Doc, I've got a sparkle box in my right eye. Last 24 to 48 hours. I woke up yesterday morning with this sparkle box, or this morning with this sparkle box just inferior to fixation. There's a kind of a centered view of the back of this right eye. You can see the optic nerve. The left eye was completely normal. I won't show you the picture, but left eye completely normal in this particular case. OCT. And you take a look at the OCT here, average 162 right there. Nasally, we're at 113. And clearly you can see, look, it's interesting. Obviously, it looks much more superior, half of the nerve in this eye. OCT matches it very, very nicely. Look at the difference between superior and inferior in this particular case. Here's the other eye. The left eye, the non-involved eye, we're at 114. Nasally, we're right at that number, 88, as you can see right here. Looks overall pretty good in that uninvolved left eye. Here is the OCT, the qualitative, kind of cutting through the top part of the nerve. And you can see here, and you can see here as well. And you take a look right there. That's above the nerve. I got a little video here. Just kind of show you in real time as we're moving.
Yeah, great.
Go ahead and have a seat for me right here.
Official commentary.
And you can see at the bottom of the part nerve looks pretty good. You get to the top of the part, significant elevation, as you can see right there. So in this 67-year-old female, 67-year-old female comes into your practice, doc, I woke up this morning, I got a sparkle box in the inferior part of my, just below fixation in my right eye. She's 20/20 minus. She appears to be without an APD. Back of the eye looks like this. OCT. We showed you the OCTs as well. There's the OCTs right there. So in this 67-year-old female, what is your diagnosis? A peripapillary choroidal neovascular membrane, NAION, AAION/giant cell arteritis, papilledema, compressive optic neuropathy, or optic neuritis. What do you think in this case right here? We are unanimous in the chat box, strongly leaning towards an NAION, and via the poll everywhere, we are also strongly leaning towards an NAION, really strongly leaning towards an ischemic optic neuropathy, much more NAION versus giant cell arteritis, horses versus zebras. I was fortunate in this case that she had had some recent blood work, so I knew what her SED rate and C-reactive protein is. She had no tenderness or scalp tenderness or pain right here, no headaches, no malaise, lack of energy, joint pains. She had nothing like that. So I felt comfortable that this was not an AAION or giant cell arteritis. Vision probably too good for that with no APD. So I settled on a diagnosis, I agree with you guys, of an NAION. Follow-up question, and maybe my last question of the night, is how would you manage this patient? Would this be oral steroids? Would you refer this out to neuro-ophthalmology? Would you observe this? Would you refer out to retina, MRI to rule out a mass, MRI with flare to diagnose MS, or weight loss with Diamox? Let's assume you're going to consult with their doctor. You're going to manage the things that can go along with NAION, like blood pressure, vascular stuff. Let's assume you're going to do that. Anything else you would do? Would you oral steroids, refer out to neuro-ophthalmology, observe this, refer out to retina? What do you think in this case? I'd be curious to see what your guys' thoughts were. Go back to our answers. 1, 2, 3. We got a lot of the chat box. We're referring out. Got a lot of refers to neuro-ophthalmology, referring out to retina. We'll see what you guys are thinking via the poll everywhere here. Okay, and I think those are all good answers. There's a lot of correct answers in this case. Referring out to neuro-ophthalmology is number 1. Observing is number 2. I think that shows the wide range of what you could do in this case. Of you could just observe this if you wanted to. That's what I elected to do in this case, was just observe it, because I think what's neuro-ophthalmology going to do in this case? They're going to observe this as well. But I wouldn't fault you if you referred this out. I elected to observe in this particular case. So that was my diagnosis, a mild NAION, the horse's horse in swollen optic nerves. The number 1 cause of a swollen optic nerve in somebody over the age of 50 is an NAION. So it's the horse in this case. Symptoms presented just like they often present with an NAION. Observe, blood pressure monitoring, consult with their doctor. And I said, I'm going to see you back in about 2 weeks. You may go longer, you may go shorter. I said 2 weeks for follow-up in this case. 2 weeks later, the sparkle box is better. It's getting smaller. So subjectively, we're moving in the right direction. Vision-wise, still about 20/20 shaky in that right eye. And here's the back of the eye. This was the day of diagnosis. And here is 14 days later. You ready? There we go. It's interesting. In 14 days, in 2 weeks, we went from this to that right there. Definite showing improvement in 14 days right there. There's just another picture of that eye. Here's the visual field on that visit number 2. Again, visit number 2 in this visual field, as you can see right here, the defects that we're seeing in this right eye. OCT in, again, 14 days went from 162 overall. Notice the 210 and 114, and notice this area right here to that in 14 days. So again, take your photos, as Joe said, take an OCT, as we've been talking about, and notice the improvement that we're seeing in 14 days. All of these numbers getting better, nasally, temporally, again, all looking very, very good there. And guess what? That V sign, those pockets of fluid getting much better in this eye as well. So we've got an improving NAION, observe, blood pressure monitoring. I'll see you back in about a month for follow-up. 3 to 4 weeks later, the sparkle box is gone. Vision is good. There's the nerve. Again, over the course of 3 visits, it went from that to 2 weeks later to 3 weeks or after that, boom, 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 getting a little bit better, I think, each time. And guess what? The visual field from visit 2 to visit 3 getting better as well in this particular case. OCT, visit 1, visit 2, visit 3. Again, getting better each case from visit 1 to visit 2 to visit 3. OCT getting better as well. We've got a resolving mild NAION, blood pressure monitoring, observing 1 month or 6 weeks for follow-up. So NAION, the number one cause of reduced vision in your patients over the age of 50 years old, as we've talked about. I had her bring in this. She was a very good patient, very reliable patient. And look what she brought in. She brought in her blood pressure log as I was seeing her over these multiple visits, was taking a look at this, and you can see, where's the blood pressure reading? Is it high? Is it low? That diastolic, where is it at in these cases? Again, nice to see there. I don't want it hovering around, diastolic at 56. Most of the time it was not in these particular cases there. So again, I'm out of time. I want to get through one more case in 1 to 2 weeks, in 1 to 2 minutes, I should say. But remember, the number one cause of a swollen optic nerve in your patients over the age of 50. I want to finish with this one. What's classic case of NAION? Right eye looks good, left eye looks swollen in a patient that's a little bit older, and the classic visual field defect of that inferior altitudinal, as we're all very familiar with right there. Last case in my last minute or two. 80-year-old female. Vision went out in my left eye 2 days ago, doc. All right, vision. You've all had patients that my vision's blurry. I can't see anything. And they're 20/25 or they're 20/30. She said, I can't see anything. My vision went out 2 days ago, my left eye. I just don't feel well. Diabetes, hypertension, RA, vision's just gone. Guess what? Vision's just gone. She's NLP in that left eye, 20/60 in the right eye. She's got a 4+ APD in this particular case. There's the back of the right eye. Again, we're diabetic, we're hypertensive, we're 20/60 in this eye, we're NLP times 2 days in this eye with a whopping monstrous APD in this particular case. So there's the back of the left eye. Again, come in, doc, my vision went out in my left eye 2 days ago. It's gone. Sure enough, NLP, 4+ APD in this left eye. There's the back of the left eye. Here's the back of the right eye, just to remind you in this particular case. I'm going to finish with this question. What's your diagnosis in this 80-year-old female? Quick case here. Is it a vein occlusion? Is it a central retinal artery occlusion, optic neuritis, diabetic papillitis, hypertensive retinopathy, NAION, or AAION? What are your thoughts in this particular case? Very quickly. I think it's important to get this diagnosis right, and it's not an easy diagnosis. Certainly, we have a cherry red spot. You can see what's going on here. We've got an artery occlusion going on, but don't forget about what other things could be going on as well. Again, love the answers. I think they're all correct answers, but don't forget about what we have going on in both eyes. We have got certainly a swollen optic nerve, which you don't often aren't going to see with just a pure central retinal artery occlusion. This is an 80-year-old female with some malaise, some fatigue. She's not feeling well. You need to not forget about giant cell arteritis in this particular case, an AAION. You're seeing all this stuff, as you can see right here, even in the other eye as well, where you're going, are those margins a little bit indistinct? Maybe, maybe not. We've got the cotton wool spots as well. Again, I think these are great answers. There's definitely a central retinal artery occlusion, but don't forget about that AAION. What's the most important? I'm not going to open it up at this time. I'd say it's the SED rate and the C-reactive protein. And guess what? SED rate and the C-reactive protein was right there. We're significantly elevated in both of those, and the diagnosis was a central retinal artery occlusion in the left eye, secondary to giant cell arteritis, temporal arteritis. The left eye is very, very, very likely gone, but we don't want to just diagnose an artery occlusion and start scanning the carotids and worrying about plaques when we've got that other eye, that right eye, to save from a systemic inflammatory disease like temporal arteritis or giant cell arteritis in that case. So certainly it's a zebra. It's not one of the most common, but remember your ischemic optic neuropathies from giant cell arteritis as well. So with that, Greg, Joe, I think we are out of time, buddies.
Yeah, that was excellent, Nate. It was a great review. There was a great number of clinical pearls for everybody. I thought you were spot on. You had a lot of really elegant and eloquent explanations for things. So I think that was a very, very worthwhile webinar. So we really appreciate you coming on and doing that for us. So thank you.
Thank you, sir. My pleasure to be here.
Yes, Nate, thank you for doing that. And I want to thank everyone for attending Nate's Swollen Optic Nerves. Now what? I couldn't say it any better. It was just a great job, Nate. So thank you for doing that for us.